a very good old friend. We've met a lot and we've exchanged our scientific experiences through the last years in many conferences all over the world. I'm honored to present him now. He will be talking about radiotherapy in the era of COVID-19. Dr. Bilal El-Hawari is a radiation clinical oncologist. He's a radiation clinical oncologist, consultant. He's an Australian fellow in radiation oncology from Sydney University. He was previously the head of the section of radiation therapy department in the Royal Medical Services in Jordan. He's a pediatric radiation therapy training at MD Anderson Cancer Center, Texas, USA, and adult radiotherapy training at Heidelberg University in Germany. Dr. Bilal will be presenting to us radiotherapy in the era of COVID-19. I'd like first to thank him and to thank the Worldwide Academy for this nice opportunity they gave me to chair this wonderful session. Please go on, Dr. Bilal.
Thank you, Dr. Rostom, for this nice introduction. It's my pleasure to be to give this lecture for our professors in Egypt and in the whole Arab world. Thank you for the audience and thank you for the Worldwide Academy. Actually, what I'm going to talk is the radiotherapy in the era of COVID-19. This is something new. The latest or the oldest reference I have is was three months ago. What we are going to talk about, first I will try to give some introduction about the coronavirus. Then I will give what are the modifications that we did in every type of cancer. Of course, the most common cancers, lung cancer, colorectal cancer. And lastly, we'll talk about the most common cancer in females, which is the breast cancer. And lastly, I will give two slides about what about brachytherapy? Do we need to stop the brachytherapy suites in our cancer centers or to continue? This is what we will hear. Officially, COVID-19 was discovered as a novel beta coronavirus in the 9th of January 2020 as a clusters of severe pneumonia, which happens in Wuhan in China. And the WHO had been officially classified this new disease as a coronavirus disease 2019, COVID-19, because it was first talking about in December 2019. This was was identified as a severe acute respiratory syndrome due to similarity of the structure of its receptor binding gene to that of the severe acute respiratory syndrome virus, which caused a death of 800 deaths worldwide 20 years ago. So when it has been spread, COVID-19 has been declared by the WHO as a pandemic. The numbers now in the whole world is around 25 million affected by this disease. Most commonly, it was in USA, followed by Brazil, India, Russia, and Peru. So most of the countries in the world now has been infected. The first European patient was diagnosed in the northern of Italy. After that, almost every European country has been critically hit by the pandemic, which has been produced an emergency scenario with the huge repercussions in the public health, society, and the global economy. Restrictive measures in the social and working life has been adopted by national governments in the key of containing virus spread all over the country. Overload. Sorry, do you hear me?
I hear you, Dr. Bilal. I think there was. I think everybody is hearing you. As far as I'm hearing you, I think everybody's hearing you. You can continue. I think there was a very transient problem.
Maybe the net. I don't
Yes,
know.
yes.
But,
Maybe
so the
transient
public
problem.
health system, individuals with cancer, the cancer patient is the most patient who will suffer. This is the category of patients particularly expected to infections due to their immunosuppressive states, which can be induced both by the tumor itself and the chemotherapy that we give to the patient. Hello? So the recent paper, which published by Onder and his colleagues 3 months ago, he did an analysis on 1,500 patients and shows that of oncology patients and showed that there was a twofold increase of COVID-19 infection in the individuals with cancer in compared with the general population. This is due to the poor performance status, frequent hospital admissions, repeated well-known risk factors for contracting the virus. So different measures have been implemented in the cancer centers in order to reduce the impact of this epidemic on oncological patients, such as providing clear instructions about the hand hygiene and the stronger personal protective equipment, and a more intensive surveillance or treatment of the infected patient, and a careful concentration of postponing elective surgery and scheduled treatment, especially for the tumors of the low risk, like prostate cancer. So we'll try in prostate cancer to concentrate, as I will mention later, on the hormonal therapy to delay the patient going to radiotherapy. And there is a belief that therapeutic management of these patients should require a careful risk-benefit assessment. So it is virus expected and the treatment outcome. So most cancer centers in Europe have adopted specific measures to recognize their healthcare system in order to ensure that the continuity of cancer care during this outbreak. So in this setting, radiation therapy clinical decision-making process and workflow has been partially rethought with the aim to reduce the contact and optimize the workflow, and at the same time to ensure the appropriateness and effectiveness of the therapeutic approach. We know that a common course of radiation therapy usually takes 5 to 8 weeks for its completion. The appropriate hypofractionation regimen should be considered during this pandemic in order to reduce the treatment duration and minimize the risk of infection. Radiotherapy usually requires the daily attendance, and its early interruption can preclude the expected outcome, especially in the head and neck cancers, which is any delay or any interruption in the treatment will affect the response dramatically. So therefore, patients have already started the treatment should continue their scheduled therapeutic program. This patient, I mean a normal patient, not the patient who is infected with the COVID-19 or the coronavirus. We will talk about the coronavirus patient infected during treatment according to their, I will talk there later about that, but about the symptoms. When there is good symptoms, small symptoms, low cough, no chest pain, no difficulty in breathing, we can continue the patient on his treatment, especially I mentioned in the head and neck. So when it's programmed to be administered as a curative intense radiotherapy for an active treatment, there may be no alternative to proceed with the treatment following safety precautions, as well as for urgent and non-deferrable treatment. But in the contrary, it may be reasonable to explore different therapeutic strategies. Example, when radiotherapy is given for a palliative treatment, we can give opioid or non-steroidal anti-inflammatory drugs, and when it can be safely postponed in the context of an integrated clinical management of disease to limit the access to the hospital, as using neoadjuvant hormonal therapy in prostate cancer. What do I mean neoadjuvant? That the extended neoadjuvant. We know that in intermediate risk and high risk prostate cancer patient, we give 2 months neoadjuvant hormonal therapy. But in the era of COVID-19, we can extend this to 4 to 6 months to delay the access to the hospital. However, combined regimens, especially when most toxic chemotherapeutic agents are included, may significantly increase the risk of morbidity and mortality in infected patients. Therefore, it should be carefully considered, especially in lymphomas. Now, we will talk about every specific cancer. I will start with the most common cancers in males, which is the lung cancer, followed by the colorectal cancer, and lastly, we will talk about the breast cancer. Regarding lung cancer, estro and astro practice recommendation on lung cancer was recently uploaded on the inline version for the radiotherapy and the oncology. And they recommend that there was a strong consensus between experts in advising not to postpone radiotherapy for curative treatment of stage 3 non-small cell lung cancer, limited stage small cell lung cancer, and the palliative non-small cell lung cancer, especially when it's in the bone and will cause spinal cord compression. But in the contrary, post-operative radiotherapy in non-small cell lung cancer and prophylactic cranial irradiation in small cell lung cancer should be delayed. Hyperfractionated regimens are particularly encouraged in the setting of exclusive radical treatment or sequential chemoradiotherapy for stage 3 non-small cell lung cancer, while they should not be offered for concomitant chemoradiotherapy. Also, they recommend stereotactic body radiosurgery for stage 1 non-small cell lung cancer. And we know that it is equivalent to surgery to delay the post-operative treatment and post-operative stay of the patient in the hospital. Regarding the rectal cancer, the data available for the locally advanced rectal cancer suggests to favor, in this particular time, short course radiotherapy regimen, which is 25 gray in 5 fractions, followed by delayed surgery. When we use this in an old patient, 25 gray over 5 fractions, this was followed by surgery after 1 week. But in the era of the COVID-19, it will be 5 to 13 weeks. And also for T3 and node positive patients, and to preserve long course radiotherapy, which is the 50.4 or 55 gray in 1.8 gray body fraction and concomitant chemoradiotherapy for the T4 disease. And the NCCN guidelines sustain short course radiotherapy and recommend the association with the oral therapeutic Xeloda instead of the systemic IV, because it will be, if we want to give it 5 days in the German protocol, 5 days in the first week and 5 days in the last week, it will take time and the patient need admission to hospital. For prostate cancer, active surveillance should be performed for the low risk patients, while neoadjuvant hormonal therapy strategy with longer formulation, as I mentioned, 4 to 6 months, could represent a valid option in order to postpone radical treatment in intermediate and high-risk prostate cancer. Early salvage radiotherapy should be chosen over adjuvant radiation therapy after radical prostatectomy, even in the presence of unfavorable prognostic factors, which is high Gleason score and positive margin. So this therapeutic strategy has been significantly supported by the recent evidence coming from the ravis and the radicals. So when it is feasible, shorter radiotherapy regimens with a 60 gray in 20 fractions, or we should take only 5 to 6 fractions in total, and this will be preferred. Head and neck cancer, which is a problem in radiotherapy because it needs a particular attention, should be addressed to the head and neck cancer patient because these are fragile population when often undergo massive surgery followed by a concomitant chemoradiotherapy or a concomitant chemotherapy from the start, which can be easily lead to an immunocompromised patient. The Astro and Estro recently published a recommendation in their sites, and the panels agreed not to postpone radiotherapy by more than 4 to 6 weeks for oropharyngeal cancers, T2 node positive, laryngeal tumors with impaired vocal cord, which is T3 node positive, and the early laryngeal cancer, where the treatment by radiotherapy is the sole treatment for this patient, which is T1B N0M0 and T1A, metastatic hypopharyngeal cancer, which is T4N1, and oral cavity T2 N2 cancers. But they also suggest that high priority for the head and neck squamous cell carcinoma, radical radiotherapy and post-operative radiotherapy for the positive margin. This is a high priority. It also recommends that to delay radiotherapy until recovery from the COVID-19 infection, to continue radiotherapy for patients presenting with mild respiratory symptoms, cough, but not regular everyday activity, especially if they have already started on radiotherapy and completed their 2 weeks of treatment. So in this era, we cannot stop radiotherapy, and we can interrupt radiotherapy in case that the symptoms are severe, chest pain, cough, and breathing difficulty, and if they need oxygen support, because we need to put the mask over the patient, and the patient cannot lay flat for 7 to 10 minutes to take, especially we use to treat the head and neck cancers with IMRT. And shortening the overall treatment time of concomitant chemoradiotherapy by using accelerated schedules, right? 6 fractions per week, or during IMRT to use the simultaneous integrated boost. We use different doses in the same BTV, and this simultaneous integrated boost technique may also represent an opportunity strategy to be considered in this coronavirus era. Breast cancer, the most common cancer in female in the whole world. They have identified 3 priority levels for the treatment of breast cancers. First, patients who need urgent treatment. Second, patients who should start treatment before the end of the pandemic, and patients for whom therapy can be safely rescheduled until the pandemic is over. Moderate hypofractionation schemes are strongly recommended because they both reduce the treatment duration and patient exposure. Hence, when an extra dose to the tumor bed is clinically indicated, it should be preferably be simultaneously and integrated. Once weekly fraction over 5 weeks, which is 20 gray to 30 gray in the first study, or 5 daily fractions over 1 week. 26 gray in the fast forward have to be considered as a valid option in selected patient, as well as a safe omission of treatment for elderly patients who underwent adjuvant endocrine therapy, especially if they are estrogen receptor positive, both ER and BR, and HER2 receptor negative. What we used clinically is that we tried in our center to give the hypofractionated regimen. It is the 40 gray over 15 fractions. This is this is the most, we find that this is the most acceptable by the patient and less side effects. Concerning technique of brachytherapy in the breast cancer, the brachytherapy suites or brachytherapy in prostate breast cancer, do we need? It should be considered as a high level of priority. Of all these patients diagnosed with a gynecological breast or prostate cancer for whom compromising options endocrine may be not possible for the triple, especially the triple negative patient, and to reduce the patient exposure and reassures utilization is an important issue to be weighted during COVID-19. Therefore, it is advisable to maintain the brachytherapy services available for oncological and breast cancer patient. By this, I finished my presentation. Thank you for the audience and thank you for Dr. Rostam.
Thank you very much, Dr. Bilal, for this nice, comprehensive talk about the role of radiotherapy and in COVID-19 infection. Can I start with a question from Dr. David Hankish? He is asking you about what are some practical steps that can be done to protect clinical staff.
There is many. The practical stuff is the most important stuff. They are more important now to take concern about them, because if we lost them, as what happened in Egypt during the first attack of the COVID-19, even in Jordan and some other countries, there is a low concern about the COVID-19 and the infections, the severity of the infection that caused. But I want first to say that in August, the last month, the WHO said that there was a mutation of the COVID-19 virus, and now the virus is more spread, but it is less toxic. So the patients who will need to be admitted and intubated are now less and less. This is thanks God for this happened. So the first thing we do in our centers, that we advised any consultant or any doctor, an radiation oncologist who does not have a patient or active patient in treatment, or want to do any kind of starting or initiated treatment of the patient, not to come to the center to reduce the chance of getting the infection. And the staffs, they need to be concerned about putting the mask, social distance with the patient, right? Every patient to be deal with any patient that, or any suspected patient, that he is a coronavirus positive till proved otherwise. We know that the PCR, it is not an 100% accurate to give us the clue that this is he is positive. Also, we face this now in Jordan. We opened something called Manassa, that any one from other Arab countries, especially Iraq and Saudi Arabia, who want to come to Jordan to be treated, we put the patients for the first week in the hospital isolation, but the doctor, the oncological doctor, goes to them and examine the patient, but with the strict equipment, that as if he is dealing with a COVID-19 patient. Even if the patient, before he come to Jordan, he did the PCR, which is negative, and when he come to the airport, he did the PCR and comes negative, and after 3 days we do the PCR, which is negative. But don't depend on your luck in this, because الوقاية خير من العلاج.
Very comprehensive answer. My dear friend, Dr. Muhammad Adel is asking you about, should we assess patients via telephone or telemedicine? Of course, suspected COVID patients via telephone or telemedicine to avoid them from entering the hospitals?
We did something unique here in our center, that we did a WhatsApp group for the patients, and anyone who have a question, please ask your doctor, and we will answer your questions. You will not believe it. They ask questions that it is, doctor, can I eat today if they are doing bamia on lunch? You do not expect these questions. I believe that our patient is very kind and wants to ask questions. You know, the most of the patient and most of the doctor also, we are in the quarantine, we are like a prison, but in our house. They want to just to talk with anyone. Asking the patient, if you have any complaint, please don't come to the emergency room. This is the policy that we did. Don't come to the emergency room, just call the doctor. If he said you have to come, your symptoms is severe, we need to examine you, we need to give you oxygen, anything else, yes, please come to the hospital. We find this is valid, but ask your patient, please don't send me good morning, happy Jum'ah Mubarakah. These things that we usually they did in the social WhatsApp message, to be more business, more for the active, for the nice questions, that urgent questions, any patient want to do it. We have a good experience with that, and we find it very helpful for the patient and very noisy for the doctor.
Thank you for this. First of all, I want to greet you about the Jordanian experience in combating COVID-19. You've had a very strict and good measures to combat the spread of COVID-19. Opinion about the concurrent boost of breast cancer, because if you are giving 3 weeks of 4 or 15, you can do as well concomitant boost. I think this can prevent the brachytherapy boost in case of breast cancer.
Yes, if the brachytherapy is not available, so we used, when I was in the United States, when they said let's start to do the hypofractionation in the breast, and said, let's say if you want, if you go to the guidelines, it says that the patient who does not need to the boost. But when we want to discuss, can we give a boost? Yeah, but this is not recommended, but we will not, we want to do it. Yeah, we usually give, if there is a need for the boost, yes, we give the hypofractionated regimen, and we give the boost by 5, by the normal, by 2 gray in 5 fractions.
I think this is a very good way to avoid many visits to the hospital to take brachytherapy or boost alone. We have the same question from Dr. David Hanschke about should we assess patients via telephone or telemedicine to avoid entering the hospital. I think we have already answered this. And I think we all do this all over the world. When our patients talk to the hospital, to the specialist, or even talk to us, we can give them some advices that if they have fever or cough or even now diarrhea, they can go to either specialized COVID-19 hospitals or doctors who treat chest diseases. Any other questions from all our friends and participants?
Good.
Sorry?
Sorry.
Any other questions from our friends or participants? Now, I'd like to thank Dr. Bilal for this very nice and comprehensive presentation about radiotherapy in the era of COVID-19. It was a very nice, comprehensive talk. He showed us all the recommendations about radiotherapy in patient, especially in special situation like COVID-19 pandemic. Thank you, Dr. Bilal. I'd like also to extend my thanks to all our attendees and participants, especially to the organizing Dr. Muhammad Adel Sayis and Mr. Sameh for their help to deliver this nice message to all our friends and colleagues. It's always a great pleasure to be together. Now I have to end this session. Thank you very much for everybody, and I hope to meet soon, face to face, after the end of this nightmare of COVID-19. Thank you.
Thank you, Dr. Russom. Thank you for our participants. Thank you.